Picture this. Your knee has been aching for 3 days. Your back has been stiff since Tuesday. You open the medicine cabinet, take out the bottle you've had for months, shake 2 pills into your hand. You've done this dozens of times. It works. It feels completely harmless. Now picture this. That same bottle has a warning printed on the label, mandated by the FDA, that links it directly to heart attack, stroke, and heart failure. Not buried in a leaflet, on the label. And there is a very good chance no one has ever pointed that out to you. Not because your doctor doesn't care, but because it gets lost. Because the prescription was for pain. Because it feels so ordinary that the conversation never quite happens. I'm a cardiovascular surgeon. I've spent 20 years operating on hearts, and I have reviewed the medication histories of more patients than I can count. Patients who came to me after events that didn't have to happen. In almost every case, the information that could have changed things was available. It just was never clearly given to them. That ends today. In the next few minutes, I'm going to show you exactly what this drug class is doing inside your cardiovascular system after 60. Why the risk multiplies with age in ways most people never anticipate, and what you can take instead, safely, that will still control your pain. If you take ibuprofen, naproxen, or anything like them regularly, stay with me. This is for you. The drugs I'm talking about are called NSAIDs, non-steroidal anti-inflammatory drugs. You know them by their everyday names: ibuprofen, Advil, Motrin, naproxen, Aleve, Celebrex, diclofenac. These are the most widely used pain relievers in the world, and most people reach for them without a second thought. For back pain, knee pain, arthritis, headaches, inflammation that comes with age. Here is what most people never consider. These drugs were studied extensively in younger adults. The cardiovascular risks in that population are real, but relatively contained. After 60, the picture changes completely. 3 things happen as the cardiovascular system ages that transform a manageable risk into something far more serious. Arterial walls stiffen, kidney function declines, and most people are already taking other medications, blood pressure drugs, diuretics, statins, that interact with NSAIDs in ways that compound the danger. Understanding why requires looking at what these drugs actually do inside your body. NSAIDs work by blocking 2 enzymes, COX-1 and COX-2. This is what reduces pain and inflammation. It is also what creates cardiovascular risk. Here's the chain reaction that begins the moment you swallow one. First, your kidneys change how they handle sodium and water, COX. 2 inhibition in the kidneys causes fluid retention. Your blood volume increases, and increased blood volume means one thing for your heart: more pressure, more work, more strain on arterial walls that, after 60, are already less elastic than they used to be. Researchers have found that even short-term NSAID use raises blood pressure measurably. For someone already managing hypertension, that increase is not trivial. It can push a controlled condition past its threshold. Second, the balance of clotting in your blood shifts. NSAIDs alter the ratio between 2 compounds that regulate whether your blood clots or stays fluid: thromboxane and prostacyclin. When that balance tips toward clotting, the risk of a blood clot forming inside a narrowed coronary artery increases significantly. That is the mechanism behind an NSAID-triggered heart attack. Not a rare mechanism. A documented one. A meta-analysis published across multiple peer-reviewed cardiovascular journals found that non-aspirin NSAIDs are associated with a 15 to 44% increased risk of heart attack and stroke in treated patients. 15 to 44%. For something most people consider as safe as Tylenol. Third, your heart muscle faces a fluid load it was not designed to carry indefinitely. The retained sodium and water don't just raise blood pressure. They increase the total volume your heart must pump through vessels that are narrowing with age. Over days and weeks of regular use, that accumulated load can tip a marginally compensating heart into failure. This is not theoretical. The American College of Cardiology and the American Heart Association both recommend that NSAIDs be avoided or withdrawn whenever possible in patients with heart failure. And many patients with early, undiagnosed heart failure don't know they have it yet. I'll call her Dorothy. She was 71, retired nurse, knew enough about medicine to feel confident managing her own pain. She had arthritis in both hands and her right hip. She took 600 milligrams of ibuprofen twice a day, had been doing it for almost 2 years. It worked. Her pain was manageable. She never mentioned it during her annual physical because no one asked specifically, and she didn't think of it as something to report. She came to me after an emergency admission for acute heart failure. Her ejection fraction, the measure of how efficiently the heart pumps, had dropped significantly. When I reviewed her complete medication history, the daily ibuprofen was one of the first flags I raised. Combined with her blood pressure medication, her mild chronic hypertension, and the subtle kidney function decline that comes with age, she had been compounding cardiovascular stress silently for nearly 2 years. She was a nurse. She was careful. She was never told. That is the part that stays with me. I want to be precise about this because the nuance matters. Occasional NSAID use in a healthy younger adult carries relatively low cardiovascular risk. The body compensates. The kidneys recover quickly. The blood pressure effect resolves. After 60, compensation is slower. Recovery takes longer, and 2 factors accelerate the danger in ways that don't exist at younger ages. The first is polypharmacy. A landmark 2022 study from the University of Southern California tracked nearly 3,700 older adults, ages 61 to 86, over 9 years. All participants had no prior cardiovascular disease at the start. The finding was stark. Taking multiple medications with cardiovascular adverse effects simultaneously, which includes NSAIDs, combined with common drugs like antihypertensives or diuretics, doubled and sometimes tripled the risk of heart attack, stroke, or death. Not in people who were already sick, in people who appeared healthy. The second factor is kidney function. As the kidneys age, they clear medications more slowly. The cardiovascular effects of an NSAID, the fluid retention, the pressure elevation, the clotting shift, last significantly longer in a 68-year-old body than in a 35-year-old one. The same dose produces a longer, deeper effect on the cardiovascular system than the label was ever designed to account for. This is why I consider daily NSAID use in adults over 60 to be a cardiovascular conversation, not a pain management one. I'll call him Gerald. He was 74. Active man, still golfed twice a week, still drove himself to every appointment. He had been prescribed a COX-2 inhibitor for chronic lower back pain 18 months before I met him. A scan had shown mild coronary artery narrowing a year earlier. Noted. Filed. Not directly connected to his pain medication by anyone who saw him. He arrived at my hospital after a myocardial infarction on a Thursday morning. When I was in his chest, the pattern of damage was consistent with what I see in sustained, chronic cardiovascular pressure. Not a single catastrophic rupture, but accumulated compromise over time. He survived. The NSAID was stopped immediately. He manages his pain differently now. But I have stood over operating tables where the outcome was different. And in every one of those cases, when I went back through the history, the information existed. It just was never clearly given to the patient. I want to be clear about something before I give you this. I am not asking you to stop managing your pain. Pain in older adults is real. It affects sleep, mobility, mood, quality of life. Unmanaged pain has its own health consequences. What I am asking you to do is manage it differently. The first thing I tell patients in your situation is this. Before your next dose of ibuprofen or naproxen, try acetaminophen. Tylenol, at the doses recommended on the label, does not raise blood pressure. It does not cause fluid retention. It does not shift your clotting balance. For arthritis, pain, joint aches, and the chronic low-level inflammation that comes with aging, it works for a significant number of people. It is the first option in geriatric pain management guidelines precisely because it does not carry the cardiovascular burden that NSAIDs do. If the pain is in a specific joint, a knee, a hip, a shoulder, a hand, ask your doctor about Voltaren gel. This is topical diclofenac, a real NSAID, applied directly to the skin over the painful area. Because it doesn't travel through your digestive system and bloodstream the way a pill does, the systemic effects are dramatically reduced. The fluid retention, the blood pressure elevation, the clotting shift, all significantly less than with an oral tablet. It is one of the most underused tools I recommend, and one of the most effective for localized joint pain. And this is the most important thing I will say in this section, have a specific conversation with your doctor, not a general one, a specific one. Bring every medication you take, every supplement, every over-the-counter drug. Lay it out completely, and ask directly, given my age, my blood pressure, my kidney function, and everything else I'm taking, what is the cardiovascular risk of continuing an NSAID? That question takes 2 minutes. And the answer to, it may be the most important medical information you receive this year. If an oral NSAID is still genuinely necessary after that conversation, the guidance from the American Heart Association is clear. Use the lowest effective dose for the shortest possible time. Not daily, not indefinitely. With regular review. That is the standard. Most people are never told it exists. Here is something I want you to take from this video. The medications I described today are not dangerous for every person in every situation. Short-term, low-dose use in someone without cardiovascular risk factors carries a very different profile than daily use in a 70-year-old with hypertension, declining kidney function, and 3 other medications. The danger is in the gap between those two situations, and most patients are never shown where that gap begins. Now, I want to ask you something directly. Is there someone in your life, a spouse, a sibling, a parent, a close friend, who reaches for ibuprofen regularly for pain? Someone over 60 who has never connected that habit to their heart? Please share this video with them. You may not know what that does for them. But I do. Subscribe to this channel. Every week, I share medically grounded information for adults over 55, explained clearly, without noise, without anything to sell you. And leave a comment below. Tell me, Did you know about the cardiovascular risks of NSAIDs before watching this? I read the comments, and your answer might be what convinces someone else to finally ask their doctor. Take care of that heart. I'm Dr. Olivia Kessan. Before you go, something important. Everything in this video is based on published cardiovascular research and more than 20 years of clinical experience. But research applies to populations. Your doctor applies it to you. Your age, your medications, your kidney function, your blood pressure history. That combination is yours alone. No video can account for it. No surgeon who hasn't. Examined, you should make decisions for you. Do not stop, adjust, or switch any medication based on what you've heard here. Not NSAIDs, not blood pressure drugs, not anything, without first speaking directly with your healthcare provider. What I want you to walk away with is not a decision. It's a conversation you now know to have. That conversation, with your own doctor, about your own history, is where the real protection happens. This video opens the door. Your physician walks you through it. Please don't skip that step.